next stuff. Hey, we've only done lower body. You're scaring me, dude.
Huh?
You're scaring me.
Alright, so
elbow. That's just on this side.
Elbow drill is one of those tricky ones to do that for some reason doing draws on elbows it can be bothersome, but really not that bad. We've talked about it. We've got our ulnar collateral ligaments, we've got 3 bands on it.
Bands make
Probably
me
have
down.
a picture here somewhere. Oh, there we go.
Bands
So,
make me down.
we've got 3 bands on that ulnar side. We have a common flexor group that comes off from around it. We have the lateral side, the LCL, with the radial collateral that kind of tethers that radial head in there. So it's not a nightmare, but for some reason I'm doing evals, it just bothers me. But here's a whole list of funness that can happen with the elbow. So, distal biceps tendon rupture. We'll start with that bad boy. It's fun. Again, like predisposing, like what can cause it? It can, for whatever reason, just like the Achilles, they can just pop out of nowhere. I've seen it happen with a dude bowling. Just pulls it back, starts to go, and as he goes back, that eccentric load, which is a lot of what she talked about with the Achilles tendon, put that eccentric on there, and it just went. And as he came forward, he looks down, and there's just a ball of a muscle sitting right there. Surgical reattachment to do it, a little bit of mobilization, get some range of motion afterwards. It's not a nightmare, but it's definitely something that's a little unpleasant. Immobilize and flexion and apply ice, 2 surgical options. The problem here, though, is that we end up with 2 there's just, and maybe that's part of their issue with doing evals on the elbow, that there's a density issue of the amount of stuff in the region. Because we have 3 fun, happy nerves in there. What are those?
Radial, ulnar,
Radial, ulnar, and median. Good. So all of those kind of go through this tight, compact space. They're all pretty well-defined structures with lots of little branches to other muscles in the region. And so one surgical option, we have a significant risk of radial nerve trauma, and the other one is a heterotopic bone formation, to where from the surgical intervention, some of that starts putting bone in where you surgically went in place, which is going to make life a little difficult to rehab after the fact. Ulnar collateral ligament injuries. Now, we start getting into, where do we hear about these? Tommy John's pitchers, right? So you ever watch a pitcher and they go, I mean, the amount of torque that they put, so there's 2 phases that we really have issues with. It's that cocking phase, just the motion here, and then leading with the elbow, leads with pretty much the medial side of the elbow, which puts a lot of strain on that joint. So just the process of throwing opens up and puts a lot of torque on that ligament. And then you've got all the rotation that goes along with that as they try to put spin and all kinds of fun, interesting components to their pitches. And so from that we get these problems. And it's differentiating, it's really easy to say, this is a UCL sprain. And this is a flexor muscle tendon problem. And this is an osteophyte in the joint space. But there's all of these grades of which is causing which and at what point are you there. And that's really that differential diagnosis of identifying at what point do you have an issue, what point do you have a surgical intervention, what point do you have a problem that's going to go beyond just some light therapy. So, ulnar collateral ligament injury, pain during activities created valgus load, throwing can lead to chronic instability. Because if we keep stretching it, it's more like stretching out a string than a rubber band, because it's not going to keep going back to the same spot all the time, especially if we keep doing this over and over and over. 80 to 100 pitches in a game, and you're paid to do that over and over and over, or you're 12 and you think you want to get paid to do that forever. We tend to throw these and create these problems. So, possible radiculopathy from ulnar nerve involvement. What is radiculopathy?
It's ridiculous.
It's ridiculous. It's a ridiculous word. Anybody have an idea what radiculopathy means?
Radio collateral. Wait, just kidding.
The outside.
You're trying hard. This is one of those that's got nothing. It doesn't break down that way. This is radiating problems from a nerve.
Okay.
So where you've got a nerve involvement. So we've got the ulnar collateral ligament. The nerve goes in the groove right behind it. And so by having that constant stress, valgus stress to open it up, you can actually put traction and damage the ulnar nerve, which means you'll get weakness radiating down to the rest of the hand. You can get sensitivity down the rest of the hand. Weakness is going to be significant because if you go and grip somebody and you don't have the ulnar nerve, you're missing. Oh, here's a question. What are you missing?
Bones?
So if I damage the ulnar nerve, which muscles are involved?
The digiti.
Extensor digiti.
Flexor digiti. Flexor digiti minimi and flexor carpi.
Flexor digiti.
Flexor carpi ulnaris.
Profundus.
So flex is that part of the wrist, and then the other one is flexor digitorum profundus to fourth and fifth.
This is right.
So you don't have the ability to finish off that
As is
grip.
it?
You have weakness there. You
This
can't.
is where I'm saying.
You'll have weakness in squeezing somebody's hand.
Why not the superficialis? Isn't it connect there as well?
It
Is
inserts distally there, but it originates and it's more superficial. And because it's more superficial, it takes the median nerve.
Profundus. Which
Okay.
is
Profundus.
You with me?
Yeah.
So profundus is right there along the bones
on the-
line, so the ulnar nerve comes posteriorly and hits the inside through here, but everything superficial is on the
Okay.
So if you remember, if you go and shake somebody's hand, but try to shake their hand with 3 fingers, you lose a whole lot of strength compared to what you can do with opposition. It just changes things. So you're going to notice pretty quickly if you start doing that. But then again, at the same time, you've got somebody who's coming in every single day and they're saying, yeah, this hurts, and you get in the rut of giving them constant treatment. You give them some heat, some stim, trying to manage the symptoms. Bless you. As it's progressing and getting worse, unless you're doing your due diligence and reassessing for new problems and new injury patterns, it's really easy to start missing these things. And all of a sudden, it's not getting better, you send them to a doc, and the doc's like, what have you been missing? This joint opens wide up. So, again, this is one of the things that it happens over time, so you need to be diligent on staying in touch with how it's progressing. Biomechanics, peak angular velocities and valgus stress are in late cocking and early acceleration phase. So as you're leaning forward, you're putting a lot of torque in that elbow by transferring that load to accelerate that ball. This is a problem that you rarely see in many other sports. Baseball pitchers are somewhat unique in their fun this year. That's how you have softball pitchers, you can pitch back-to-back games, because underhanded is just nicer to your body. Management, rest and NSAIDs. So if we can pull you out, get it to calm down, it should heal itself as long as we take away the source of the problem. However, in taking away the source of the problem is convincing the person to stop doing what they're doing. Because if we keep putting that stress on it and keep playing it, it's going to keep getting that same irritation. So we really have to intervene to kind of break that cycle. If it's been going on and like, yeah, it's been hurting for 6 months, well, it's going to take some time to pull them out. If that pain just originally starts up, it's been going on for a week, it's going to be easier to get it to back off and heal. Concerted efforts work in about half the patients, and you should attempt those concerted efforts for 3 to 6 months. So what do we want to do? Well, what originates above the joint line? I mean, we've got the common flexor groups, all of the muscles. So a lot of them, your flexor carpi ulnaris, flexor carpi radialis, all of those are originating above the joint space. You have the common flexor origination point. So if we work on some stabilization by having those muscles strengthened, that can help stabilize some of the positioning of the joint. And then rest with NSAIDs to help manage some of that inflammation, to help it calm down and heal, and certainly pull them out of what they're doing at this point to get it to not have that constant stress. However, there is a surgical management, because if it does get stretched too far, then we're not going to do so well. It's not going to recover as it needs to. It'll stay stretched. And again, as long as it's unstable, we run the risk of having ulnar nerve involvement. So, valgus stress is avoided for 4 months after the repair. What is the repair? Tommy John, they go and take the palmaris longus out of the opposite side, and they go and drill a series of holes over on this side, and basically reconstruct a ligament out of the tendon of the palmaris longus. So just like your ACL, we're kind of recreating it with a tendon from somewhere else. And it takes some time. Now we've gotten good at doing it, to the point that you'll now see it get done on 12, 13, 14-year-olds, which is really pretty sad, because there's no need to have some child going to that extreme to where you're having biomechanical stresses that are destroying the joint legs. but it works. 9 to 12 months rehabilitation. And the kicker is there's kind of this underlying belief in some circles that, oh, if I get it done, I'll come back and be able to throw faster. Oh, if I do this, then I can be a stronger pitcher. Well, let's look at it this way. If you're throwing a 90-mile-an-hour fastball, and every day is hurting more and more and more, so you're losing a few miles per hour here and there. So it's been going on for a year, you're down to throwing about 88, 87, and we say, you're done, we've got to pull you out, you're having a hard time, we go and we repair it. I give you to a physical therapist, and the physical therapist looks at all of you and goes, okay, well, here's some biomechanical problems with your form, here's some issues with weaknesses that we have, so let's work on all of that while we're waiting for this to heal post-surgery. So I fix your weaknesses and I fix the strength issues that go along with it, and I might even fix your throwing form. And yeah, you're going to come back throwing better, but it's got nothing to do with the surgery. It's because you just spent 9 to 12 months focusing on your weaknesses. Now, if we all just stopped what we were doing, like academically, and took 9 to 12 months to fix our weaknesses, saying, I don't study very well, let me learn how to study right. I could learn to read a little bit more efficiently. I could learn to take a test a little bit better. You'd come back in a year and be a lot better student.